In the complete hemodialysis series, one common complication which can occur during dialysis that we are going to see today, which is chest pain. Not only over the anterior part of the chest, even back pain is also common during dialysis. Up to 1% of the patient, 1%, some literature says up to 5% can develop this chest pain. What are all the causes? The causes can be from the minor issue to a major issue. In the dialysis unit, missing a minor issue won't have any impact, but the major issue should not be missed. What is the major issue? Chest pain. Whenever it occurs, always think of angina or MI if it is severe. Commonly, because chest pain, angina or MI, even in general ward it is the same. But what is specific in dialysis? This can happen in dialysis specific to it. Hypertension and hypotension both can cause chest pain. Hypertension, acute rise in BP during dialysis. LVH, left ventricular is hypertrophied, the blood supply won't be matching, the patient might develop pain. Hypotension, when the BP goes down, again the blood vessels, the supply will go down, the patient might develop chest pain. Hypertension and hypotension are more specific during dialysis, you have to look for. Dialyzer reaction, some rare complication but serious complication like hemolysis, air embolism, pericarditis. Pericarditis immediately after dialysis is unlikely, but air embolism, hemolysis, dialyzer reaction is highly likely. So these are things which are specific to dialysis, out of which air embolism have to be diagnosed very early and promptly to save the patient. Now coming to the symptomatology. The chest pain can occur immediately after dialysis, during the course, at the end. Immediately after dialysis, you have to be very vigilant. During the course, check the BP. At the end, most likely it might be a non-specific one. So these are all the causes we have seen. But how to evaluate? When the patient tells about chest pain, always look at pulse and the blood pressure. Next one is check the sugar level. Look for the associated symptoms, whether sweating, the pain is gradually increasing or not. And in the dialysis unit, always crash cart and ECG is required. You have seen 10 patients with chest pain, all 10 patient or 100 patient might be non-specific, but one patient might be having MI. Purpose of doing ECG is not to catch the minor issue, is to catch any angina, which is very rare at the time of dialysis. It is always the BP which is the issue, but ECG we have to get it. If pulse is stable, ECG is normal, you can continue the dialysis. If chest pain is also chills and rigor, probably it might be a dialyzer reaction. Treat the dialyzer reaction, it will resolve. And whether to continue the dialysis or not. If it is a non-specific pain, ECG is fine, BP is fine, pulse is normal, yes, dialysis can be continued. Suppose if associated symptom is very high, you have to hold the dialysis for some time. Put the blood in the rotation, disconnect from the patient, because the ongoing hemolysis, many times the black color blood might not be there. Better not to take the risk, hold it for some time. After that you can restart. There won't be any harm in holding the dialysis for 10 to 15 minutes. If BP is high, control the BP, chest pain will come down. This is regarding the investigation or how to evaluate during the dialysis. Since death is there, always look for pericardial rub. Admitted patient coming from ICU or ward, pericardial rub is more common. So that time heparin free have to be given, otherwise heparin might cause bleeding, or we can say hemorrhagic pericarditis. These are specific things which are related to the dialysis and related to the auscultatory finding. Apart from this, any general condition which can cause chest pain, like costochondritis, this is common in dialysis also, non-dialysis also. Regarding further discussion I am not doing, these are things which are specific to dialysis. Treat the BP. What is the treatment? BP management. For BP management, ultrafiltrate have to be calculated correctly. A low dose of nitroglycerin or any vasodilator can be given if persistent chest pain is there. If BP is controlled, if nutrition is good, ultrafiltrate is managed correctly, patient might improve, the chest pain might not recur. And despite all these measures, up to 1%, what is 1%? Suppose if 1000 dialysis are occurring, a minimum amount of patient might be having non-specific, very mild pain, which doesn't require much treatment. With a probably a centrally acting painkiller like tramadol might be required. Always look for any GI issue. Many a times dyspepsia might mimic as chest discomfort. So this is all regarding particular things related to chest pain. In summary, just get the ECG done, ask the history, how frequently it is occurring, check the BP. That's all. Bye bye.